My name is Penny Lovett and I am a Professor of Cellular Dermatology and Oncology in the Institute of Cellular Medicine at Newcastle University, and I'm the Principal Investigator of the study that we are discussing. Cutaneous melanoma continues to be an increasing health problem worldwide, and despite advances in immunotherapy and the discovery of initially successful targeted therapies, there are still no consistently beneficial treatments for metastatic disease. And so this emphasises the acute need for credible biomarkers able to identify high-risk melanoma subgroups, as well as stratify such patients for more efficacious personalised therapeutic approaches. And so this is the reason behind our study. The study was conducted principally by Ashley McConnell, who is a final year PhD student in my lab, and who will now explain the methodology and the main findings.
To define the prognostic significance as well as the potential for targeting the CXCR4, CXCR7, CXCL12 chemokine signalling axis, we first defined the expression of individual components of this chemokine axis in human metastatic melanoma cell lines, primary cutaneous cell types, as well as in a retrospective cohort of primary melanomas and benign nevi. Using semi-quantitative immunohistochemical or immunofluorescent analysis, CXCR4 or CXCL12 expression was correlated with disease outcome over 7 years. In addition, we investigated the potential for an autocrine signalling mechanism in mediating the activation of pro-survival MAP kinase signalling in melanoma cells, and how crosstalk with this pathway may mediate tumour progression. The principal findings from the study were that the expression of CXCR4 was significantly high in melanomas which subsequently metastasized, for which stratification according to AJCC stage 2 disease revealed significantly decreased disease-free survival in patients with tumoral CXCR4 expression over 50%. In addition, increased expression of CXCL12 by stromal cells in the primary melanoma microenvironment was found to potentially protect from tumour metastasis, whereas the downregulation of CXCL12 expression by tumour cells themselves was associated with an aggressive BRAF/NRAS mutant phenotype. Furthermore, in vitro experiments demonstrating the addition of an anti-CXCL12 neutralizing antibody to BRAF mutant melanoma cells resulted in the downregulation of activated CXCR4 and MAP kinase signaling. This suggests the autocrine CXCR4 CXCL12 signaling may hyperactivate a pro-survival MAP kinase signaling pathway. The expression of the decoy chemokine receptor CXCR7 by cutaneous vascular endothelial cells, but not by primary melanomas themselves, also suggests a potential mechanism mediating tumour intravastation in the microenvironment. Collectively, these data suggest CXCR4 expression defines a potential candidate biomarker for melanoma and a means of identifying high-risk patient subgroups. Moreover, the additionally reported role of CXCR4, CXCR7, CXCL12 chemokine signalling within the primary cutaneous melanoma microenvironment highlights the potential for targeting this chemokine axis to prevent the development of metastatic disease.
As a treating clinician, I would suggest that since the increased expression of CXCR4 further refines disease outcomes over and above AJCC staging alone, this would allow for increased confidence in predicting those patients at higher risk of disease progression. This would have major impacts in terms of clinical follow-up, radiological surveillance, and also potentially earlier therapeutic intervention. Importantly, it would also allow greater clarity for patients, allowing them to plan for their futures with more available information, thus mitigating to a degree some of the uncertainty that adds further psychological burden to a patient and their families during an already difficult time.